Okay, welcome back everyone from the break. We had a nice kickoff to this meeting with a wonderful plenary from Shannon Hayter, which was followed by our really fantastic panel on prevention. And so now we're going to move on to the treatment panel. And to do that, I'm going to introduce our good colleague, Jane Simoni, who will moderate the treatment panel. Jane has been a long-term track chair for this treatment panel and adherence panel. So Jane is a clinical psychologist. She's director of clinical training in the departments of psychology at the University of Washington in Seattle. She directs the behavioral science core of the UW-CFAR. Her research is focused on behavioral aspects of HIV treatment with NIMH-funded intervention studies in New York City, Seattle, the US-Mexico border, Ghana, Haiti, and Kenya. Two of her medication adherence intervention strategies for both peer support and electronic reminders are included among those with good evidence in the CDC's dissemination program for adherence intervention. Her current work aims to employ computer technology to enhance intervention impact and dissemination. Jane, thanks for your long-term commitment to the field and to this particular conference, and I turn it over to you now.
Thank you very much. I'm assuming you can see my slide. I have one slide to introduce the HIV treatment adherence track plenary this morning or this afternoon, whatever your time zone may be. And I just wanted to say, first of all, those of you who know me know that I love this conference. I come every year. I really wish we were on the beach in Miami together, especially during breaks, but we are not. But I'm so glad you could join us anyway and that we could be here. And do reach out to us on the planning committee and those on the conference chairs if there's anything we can help you with during the conference or after. I know I've been talking to you between breaks, and I still want to give you the opportunity. If you can email me with questions, I'm happy to respond. This morning we have three excellent panelists, very different approaches to talking about treatment adherence. First, we're going to hear about exciting new long-acting art. We're on the horizon, and are we ready? Dr. Ethel Weld from Johns Hopkins School of Medicine is going to be their first panel. Next, Liz Foote from the UK and the Sussex Community Foundation Trust is going to talk about intentional art non-adherence. How can providers respond? She'll give us a nurse's or clinician perspective on that. And then finally, youth activist William Matovu from Uganda is going to talk to us about U equals U, a motivational message for HIV treatment adherence. Each are going to speak for approximately 15, 20 minutes or so. And then at the end, we are going to have a time for questions. You can put your questions or comments, I understand, in the comments box during the presentation. I will be trying to monitor that. So we hope to be able to answer any of your questions at the end of the three presentations. So if we're all set, we can move to Dr. Ethel Weld, who will talk to us about long-acting art. Thank you very much.
All right, so let me just go ahead and share my screen. Okay, excuse me, let me go back to the beginning. All right, so hello, thank you so much, Jane. It's really a privilege and a pleasure to be with you today to discuss long-acting antiretrovirals and what is on the horizon, and are we ready for them? So an outline of my talk is I'll speak a little bit about formulation and delivery fixes for adherence issues. We'll talk about some of the new aspects that come along with less frequent dosing approaches and long-acting antiretrovirals and what specific ART is coming soon and less soon. We'll put a particular spotlight on long-acting nanoformulated injectable cabotegravir and rilpivirine as they're kind of on the near horizon rather than the distant horizon, and talk about the new frontiers for those strategies. We'll speak a bit about ART implants, which are in active development but on the further horizon, and then we'll focus on what we need to do to be ready. And part of that involves identifying the questions. So this is a graph of the degree of incursion into the daily lives of an individual of various drug delivery strategies. So you can see the bottom, option E, which involves taking a pill every single day for a lifespan, is the option that involves the most daily actions from individuals. And it still may be what most or many people living with HIV choose as their treatment option. But increasingly, there are other less frequent dosing options that are in clinical testing on the horizon and will fairly soon be available in the clinic. So options A through D representing bioerodible or non-bioerodible implants that are placed surgically under the skin. Option B representing intramuscular injections, where you maybe come back in 28 days for a second load and then thereafter come every 2 months. The next is these strange starfish-shaped drug delivery devices pioneered by Robert Langer, where you swallow a small pill, it unfolds in your stomach and slowly releases drug. And option D is these microneedle patches that slow release drug. But basically, the development of ART from the moment that AZT was first approved to the evolution of safe and effective and tolerable ART with low pill burden has really been a story of variations on the theme of daily oral medications for life. And there are some life settings and some choices and some circumstances for individuals that would mean that instead of just more variations on that theme, an entire different movement is called for, and not variations on the theme of daily oral lifelong meds. So this is a very nice figure from iBase that shows the agents in the pipeline for antiretroviral treatment acting at various different stages of the HIV life cycle. I've circled the ones that are long-acting. You can see every single category is dominated by them, and I've put the dosing frequency next to them. You can see it ranges from weekly to yearly dose frequency. And I will just mention that though this spotlight of this talk is going to be on small molecule drug development, the BNAbs, the broadly neutralizing antibodies, are a robust area of development right now. Many of them are long-acting because of modifications made to the FC receptor to increase their affinity for and binding to the neonatal FC receptors so that the antibodies are recycled and not lysosomally degraded. So a lot of those are amenable to every 6-month dosing and are being combined with small molecules in studies. So this is a beautiful picture of the mountains, and the reason cabotegravir and rilpivirine are circled is that I believe them to be on the near horizon, as do most people who have been watching this space of long-acting antiretrovirals for years. So we will talk a bit about islatravir and lenacapavir, compounds that are highly potent and very long-acting and are in clinical development, though not yet in late-phase clinical development. And so I wanted to mention what I feel the new aspects to be about long-acting antiretrovirals. One of them is that they place centrally the issue of non-adherence, accommodating it without blame, viewing it as potentially even existing on a continuum of normal human behavior, and something that we should offer choices and options for. Directly observed by definition, distinct from the non-observed daily oral antiretroviral therapy, except in very rare occasions. So there's this delinkage of individual behavior from viral suppression. So until we investigate home self-injections or patches or things that an individual will apply at home, this is really something that it seems to be linked to coming into a clinic. One thing I thought it was appropriate to bring up at a behavioral conference is that potentially pay for performance or contingency management strategies, rewarding a behavior leads to its repetition, those sorts of ideas about incentivizing HIV positive outcomes, are that there's a decrease in the number of daily actions that need to be performed by a person living with HIV to maintain virologic suppression. And so adherence to these technologies as a function of the number of daily actions required is of interest and needs to be studied in the real world. And the real world tolerability is a huge question. We've seen many nice graphs about high acceptability in trials among participants who choose to participate in trials. But there is a trade-off between that decreased dosing frequency and the acceptability of injection site reactions and adverse events. And the other thing to note is that if you are getting an antiretroviral every month or every 2 months, your frequency of clinic visits might need to be higher than it would be with daily ART when you come in every 6 to 12 months if you're well controlled. What will the real-world frequency of missed injections be? What pricing, availability, ADAP, Ryan White, all these questions around the implementation logistics are definitely open for investigation. This is a graph at the bottom is a nice study from the Louisiana Department of Health showing an increase in viral suppression when financial incentives were offered. So just to offer you a big picture of the development of long-acting cabotegravir and rilpivirine, this top yellow region is recent regulatory milestones. So actually, Health Canada approved this combination in March of 2019. The companies submitted for FDA approval April 2019. They were issued a complete response letter in December 2019, declining to approve it at that time and citing concerns regarding chemistry and manufacturing controls and basically the ability to have batch-to-batch consistency and produce the same product each time at scale. And so then that was a setback, but the FDA resubmission went in August of 2020, and those in the know widely anticipate FDA approval in early 2021. And recently, just last month, the European Medicines Agency, CHMP Committee on Human Medicines, issued a positive opinion stating that they felt this should go forward for full regulatory approval. So it may be that our colleagues in Canada, our colleagues in Europe may be giving us insight into how this rolls out before it rolls out in this country. And the importance of all the various clinical studies showing first in the latte studies, the proof of concept that this dual drug regimen of long-acting injectables could maintain virologic suppression, then showing in the FLAIR study that viral suppression was extremely high in both the long-acting and the oral arm, and troughs remained above where they needed to be. The Atlas and Atlas 2M basically showing a high preference among those participants for long-acting ART and a preference for every 2-month injections as opposed to every one, and that there was stable virologic suppression with every 2-month injections, which was, again, corroborated in other trials. The POLAR study was a follow-on study to the latte study where participants chose long-acting CAB or long-acting rilpivirine over oral agents. A high percentage of the time, 90 out of the 97, chose to pursue that arm, and again had durable suppression. And then these customized and carry cell trials are really the first trials to explore implementation aspects of long-acting ART. This is just a slide that is from a presentation Deanna Kerrigan gave at AIDS 2020, looking at the data from the customized study, which looked at about 450 providers who provided actual long-acting injectables during care during the Atlas 2M study on many continents and 13 sites. And they looked at a primary outcome of the overall feasibility perceived by providers of monthly cabotegravir and rilpivirine. These are some of the logistical barriers and benefits perceived, most of them relating to concerns about patient management being affected by patients not returning to clinic or perhaps having minimal adherence to injection schedules. There were concerns about transportation. There were concerns about the risk of resistance due to non-adherence to injection schedule. And it varied a bit by region, as displayed in the right-hand graphs. So the new frontiers, I feel, are thinking through what is the frequency of checking viral load when you're on these medicines. Do you align it with injections? Can you space out if people remain suppressed? Is there a role for therapeutic drug monitoring, given the extreme pharmacokinetic variability of these drugs across genders, across BMI? Can levels be checked prior to injection and dictate an individualized dosing frequency? That's a black box of not really understanding whether that can happen. Can we lower injection volume to maybe decrease some of these injection site reactions? How do we identify the best candidates for long-acting antiretrovirals? How do we elevate the voice of the patient and use patient-centered approaches to do so? Where and by whom should injections be given? Should they be given in clinics, potentially community-based organizations, pharmacies? Is there a role for them being given at home, in public health settings, visiting health worker, nurse, self-injections into the thigh? These are all questions. But these are an injection volume higher than many other meds that are injected intramuscularly at home. For example, Copaxone for MS has an injection volume of 1 ml, whereas these are 3 ml injections for each drug. This is a slide depicting the benefits of islatravir. So it's being developed as both an oral option and an implant option, and really has an extremely prolonged half-life. It is an NRTI, has this translocation inhibition as well as part of its mechanism. And the half-life of the parent drug in plasma is up to 60 hours. The half-life of its active metabolite inside cells is up to 180 hours. And you can see this graph in the lower left is showing its antiviral efficacy in monotherapy after doses as low as 0.5 milligram. So it's extremely potent. The implant, you can see at the top, 2 different doses of implants sustain levels well above the PK threshold that's been identified as efficacious for PrEP and likely treatment for 12 months. This graph is showing 12 weeks. But some modeling studies have suggested that potentially this could go forward with an implant that would be dosed every year. This is lenacapavir, which is a first-in-class agent which inhibits multiple different functions that are dependent on the capsid protein, so at multiple different steps in the HIV life cycle. It has extremely potent antiviral activity, as shown on the lower left, and it has favorable kinetics. You can see the yellow line is actually number of weeks post-dose. And that's 3 months, and then this gray line is 6 months. So that the kinetics of the 2 higher doses are such that they maintain potentially therapeutic levels for 6 months. So for oral dosing, it could be given once a week. For subcutaneous dosing, it could be given every 6 months. It does have a period early on in its dosing where it is kind of a slow uptake. It is in these absorption limited kinetics. And so this oral lead-in course is recommended in the ongoing phase 2 of these studies. So these are some advantages and disadvantages of ART implants. And I think these should be considered. I won't go through all of them, but just suffice it to say that this is a table that took me a long time to make and shows all of the implants that are being developed in the preclinical and clinical space. It's not comprehensive, but it shows many of them. And just one example here that I think is important is just that this islatravir is going forward as a potentially every 6 months or every 12 months dosed regimen, part of a regimen. So these are
Ethel, that's great. That's a beautiful slide. At the bottom, can you hit that hide stop share so we can see the whole thing? You see that at the bottom? With your cursor, can you hit hide? Yes. Go to the right and hit hide. Oops. So you want to share again. You hit stop sharing, but you just need to hit the, so just take a second. You can,
okay, so people see the screen now?
Yeah, but at the bottom, if you could hit hide instead of stop share, yeah, hit hide. There you go, so we can see your whole slide. Thank you very much.
Yeah, so this is basically, again, a busy table, but showing a summary of various implants of antiretrovirals that are in development, their size, duration of levels, etc. So just to mention that there are gaps in what we have in development. It would be nice to have multi-purpose treatment and prevention options. So combine ART with potentially other drugs like contraception, like antipsychotics, like opiate substitution therapy. So those are things that need to be studied and co-formulations that need to be considered. Prevention of vertical transmission, not only perinatally, but postnatally during breastfeeding, will be something that should really be, this is an area where these can help because it's an area where it's easy to be lost to care. It's a very time period of chaos in one's life, and it's hard to come into the clinic. So long-acting ART for hepatitis B, which the mortality burden of which globally dwarfs that of HIV. What are the partners for the various drugs, and how well do the PK profiles need to match? Looking at some local tissue necrosis issues with some of the implants that have been studying, looking to modeling to predict which molecules and formulations will cause local toxicity, so it doesn't take us out of the blue. So I put these quotes just to say that it's our job as a community of people living with HIV or providers, people partnering with people living with HIV to seek safe, effective, and acceptable treatment that interfaces well with their lives, to be curious about how these new technologies will actually work and what we can do to optimize their use, both in advance of and after their approval and transition to the clinic. So the technology has been developed by the drug developers and the funders and participants who made the trials possible, but it's now our job to understand, as Gertrude Stein said, what are the questions about its use. So the horizon is actually a circle going 360 degrees around the observer, and there's 360 degrees in a circle. And so I just want to emphasize that there are 360 domains, or maybe more, of considering the impact of long-acting antiretrovirals on the lives of people with HIV. So with that, I will move to thank warmly the conference organizers, the chairs, Jane for chairing the panel, and all the faculty and attendees for listening, and these are my mentors and funders. Thank you very much.
Thank you very much, Dr. Weld. And we should note, Dr. Weld is an assistant professor of medicine, pharmacology, and molecular sciences at the Johns Hopkins University School of Medicine, which he also served as an infectious disease attending physician on the HIV/AIDS service and a general infectious diseases consultation service. In her residency, she was an internist pediatrician with additional postgraduate dual subspecialty fellowship training at Johns Hopkins. So she's now board certified in clinical pharmacology and infectious diseases, and she specializes in the clinical pharmacology of anti-infective medications. She chairs several of the PACT network protocols, and her clinical research focuses broadly on improving options for the prevention and treatment of HIV in children, adolescents, and adults with HIV or at high risk for HIV in a manner that always addresses the barriers in improving treatment options, especially for children with HIV and TB co-infection. She has a strong interest in the development of novel HIV drug delivery strategies, which of course is why she did the plenary, including these long-acting medications, such as injectables and implants, that are broadly acceptable to patients and do not require daily pills. So thank you very much, Dr. Weld. Next, we have Liz Foote, who's going to talk to us about intentional ART non-adherence. How can providers respond? Liz is an independent nurse practitioner. She has a master's in drug use and addiction, and she's passionate about complex care in difficult to reach groups and empowering staff to be skilled up to deliver high quality, compassionate care to their patients. Liz started off caring for people with HIV and helping them to die peacefully and with dignity. She then worked in Cambodia for 3 years and was involved in a community HIV project where she looked after patients with HIV who lived in the slums around Phnom Penh. Most of the patients were at end of life due to the fact they could not access effective HIV medications. Liz worked as a community Macmillan nurse for 5 years and then went on to manage the HIV community team in Liverpool. She recently joined the National Health Service's Sussex Community Trust. All right, Liz, are you all set? to share your slide, and I think you're still on mute. You're still on mute.
Not coming up. Hey, can you hear
There
me?
you go. There you go. It's okay. Bear with us, folks. We're still learning the.
Thank you for the introduction. I'm trying to share my screen.
Okay. Take your time. We'll do it.
So I just need Mia to let me know that this is gonna work.
Can you go over to the individual applications?
So sorry, it's really weak.
That's all right.
Can you see that or not?
I cannot. So if you hit share screen, and I believe at the top, there's at the very top, you can click on its individual applications to share. Do you have that option?
Yeah.
Okay, good. So now we're seeing yours. Can you click on your presentation? There you go. And
Can
make
you
it.
see the presentation?
Yeah, we're seeing that. Can you click on it? Yep. And make it a full slideshow.
Okay, it's full slideshow. Can you see that?
Yes, that's perfect.
Okay.
I think we're good, Mia? Okay, great.
Okay, good. Okay.
Take it away, Liz.
Okay, so I'm here to speak to you about intentional antiretroviral non-adherence and how can we provide, how can we respond as providers. And this topic is actually really quite an emotive topic. I worked for years looking after people that were palliative and dying, and coming across patients who actually actively choose to stop taking their treatment has been really, really challenging for me as a nurse, and I know challenging for the wider healthcare professionals that have looked after these patients. So just firstly, I've got nothing to declare. So as way of an introduction, ultimately as nurses, as doctors, our aim is to promote a healthy lifestyle and to deliver really high quality care to enable our patients to live long and healthy lives. And we all know that adherence is such an important outcome measure, especially with antiretroviral therapy. Non-adherence increases the chance of becoming really unwell. It also increases people's chance of dying earlier than they should. And it also impacts health service costs as well. And there is also then a risk of resistance and onward transmission. So it also becomes a public health issue. So how do we approach and manage those patients who choose to stop taking their treatment? And this is known as intentional non-adherence. So it's very different to people that struggle with adherence. This is very intentional. So medication adherence. So non-adherence falls into two categories. And as I've just said, intentional and unintentional. So unintentional non-adherence, we come across this quite often with our more complex patients. It's when one of our patients struggles to take their tablets, and this is due to maybe drug and alcohol issues. Maybe they've got some forgetfulness. They've got other pressures in their life. They do want to be undetectable and they do want to take their medication, but life gets in the way. Intentional non-adherence is when a patient intentionally stops taking their treatment. They decide to stop taking their treatment. And we don't see this very, very often, but I have to say, in my experience of working with very complex patient caseloads, I've seen quite a lot of this, which has been a surprise to me. So medication adherence. So in order to better understand adherence to treatment, we need to consider the factors that influence a patient's choice to stop treatment. So in other words, we need to really understand why our patients have decided not to take their treatment. So applying this approach in practice requires a holistic, empathetic, and a no-blame approach. And I think it's very, very easy for us as nurses and as doctors to be quite we blame people without even meaning to. So having empathy for our patients and really trying to understand where they're coming from is absolutely vital. So we all know about the 90-90-90 targets. We want to see 90% of people aware of their HIV status, 90% of people on treatment, and 90% of those people on treatment, we want to see them virally suppressed. But as you can see from this, and this was last year's stats, but you know, we've still got a real challenge with a percentage of people, a small percentage of people that are still not virally suppressed. And why aren't they virally suppressed? So in England, and I'm sorry it's not an American stat, but there's an estimated 4% of 102,000 people diagnosed with HIV in England who are not taking their antiretroviral therapy. And why is that? So we decided, in my previous job, we decided to do a caseload review to identify reasons why patients choose to stop taking their antiretroviral therapy or struggle with adherence. And the barriers to adherence were identified. And just to make it clear again that this was all carried out in my previous job, as I've recently moved posts. So a comprehensive caseload review was undertaken to identify and explore why some positive patients decided to stop taking their ART. We, as nurses, reflected on past cases to identify key components of a best practice model moving forward in terms of how we would deal and manage these patients in the future. We found that 14% of our caseload had a detectable viral load, and of this 14%, almost half had actually chosen to stop their treatment. And the barriers to intentional non-adherence, there were quite a lot of them. So associating tablets with HIV-related stigma. In other words, I remember one patient saying to me, every time I take my tablets, it's a daily reminder I've got HIV. By not taking my tablets, I don't think about my HIV. The adoption of personal belief systems such as religion, alternative therapy, traditional medicine, and also conspiracy theorists. And one of the case studies I'm going to talk about at the end is, is an example of how religion impacted on one of my patients. Slow progressors who feel well, lack of trust in healthcare professionals, denial, fear of side effects and medication toxicity, especially for our patients that have been diagnosed a long time. This is actually a real issue for them. Medication fatigue, just absolutely worn out of having to take tablets every day. Invincibility, an optimistic bias, depression, low self-esteem, and social isolation with no incentive for good health and well-being. And I think for a lot of our complex patients who are socially isolated and have no one really to live for, why look after yourself? Why keep yourself alive when actually life is really, really difficult? Cyclical periods of good health coinciding with stopping and starting ART, a desire to survive but not with HIV, and the need to exercise control, which I think is a really important reason for why people stop taking their medication. Sometimes it's punishing their loved ones, their significant others, and sometimes it is simply a desire to die. So control issues, we can't underestimate the need for control. We all have a need for control, all of us. And for some people, choosing not to take life-sustaining treatment is about regaining some control. It's the only control that they have. And it's quite similar to the complex nature of eating disorders, such as anorexia and bulimia. And I put in this quote from Brown, who discusses the control paradox. And they talk about power struggles in therapeutic relationships. So relationships between a doctor and a patient, or a nurse and a patient, can be disastrous as they force people to feel out of control, to cling more desperately to the only control that they have. So in other words, the more we as health professionals try to take power away from our patients or enforce our opinions on people, the more the patient's symptoms and behaviors are likely to escalate. And the right to die is a highly emotive topic, as we know, and respecting someone's choice to die, to stop taking life-sustaining treatment is complex. And liberty and autonomy or self-government are sources of human dignity as well. And the General Medical Council discusses personal beliefs and medical practice, and they state, and I really love what they write here, but they state you must respect a competent patient's decision to refuse an investigation or refuse treatment, even if we think their decision is wrong or irrational. We might advise the patient of our clinical opinion, but we must not put pressure on them to accept our advice. And we all do. I've been a nurse for 25 years. I've put so much pressure on my patients in the past to adhere to their treatment and take their medication every day. So also a really important aspect of this whole topic is assessing a patient's mental capacity. So when someone is refusing treatment, it's the first thing we should be doing. We should assess their mental capacity. And capacity, as we know, means the ability to use and understand information to make a decision and communicate any decision made. And a person lacks capacity if their mind is impaired or disturbed in some way. And this means the person is unable to make a decision at that time. The other thing that's so important when we're dealing with people who have chosen to stop taking their medication, but also dealing with any of our patients, is the language we use. So compliance relates to a more paternalistic or even autocratic relationship in which someone is seen as either following instructions, they're being compliant, or they're disregarding them, they're being non-compliant. And when we label patients non-compliant as health professionals, we do this often, and this becomes a barrier to us empathizing with our patient's perspective. It prevents us understanding why our patient is unable or unwilling to adhere to their lifestyle changes, take their medication, and it places responsibility for a perceived failure to optimize health outcomes on the patient, and it assumes that health professionals know best. And actually, my challenge to all of us is we don't always know best. So concordance is an indicator of the quality of decision making in healthcare, and it depends on patients being well informed. And a concordant relationship promotes self-management of health. It's based on trust between the health professional and the patient, and it enables the patient to feel free to discuss with the health professionals providing their care how other aspects of their life influence and are influenced by health and health interventions. It's a partnership to achieve the best health and well-being outcomes, and trust is key in any of our relationships with our patients. So the role of the provider, we need to help our patients to develop strategies to incorporate lifestyle changes or medications into their routines. We need to support their family members, their significant others, and we need to support and help change of mind. Shifting emphasis from medication to other pressing issues. I had a patient, she could not take her medication because actually she didn't have enough money to feed her children. The last thing on her mind was making sure that she was undetectable. The first thing on her mind was making sure that her children were being fed every day. That needed sorting out before her medication issues. Robust MDT working and communication, advanced communication skills, listening skills, absolutely crucial. Resilience and patience. We shouldn't show we're frustrated. We should just walk with our patients on their journey and have realistic expectations. Some of our patients are never going to become undetectable, and that's okay. We need to maintain engagement, so home visits, phone, clinic appointments, and something I feel very strongly about is maintain that engagement whether someone is adhering to their treatment or not. In the past, I've seen, healthcare professionals give up on their patients because their patients aren't taking their medication. And actually, when our patients aren't taking their medication, this is when we need to stay more engaged than ever. We need to have a flexible approach to tailored care. We're their advocates, And also timely referrals to palliative care. So 1 year before anticipated death, we should be referring some of our patients to palliative care, especially those that have chosen to stop taking their treatment. We need to prepare to adjust our communication style to meet our patients' needs, and ask about prior experiences of medication to identify any problems. I had a patient who had had to have 2 hip replacements because he was originally put on a regimen and his GP put him on steroids, and the consultants and the GPs weren't aware of what each other had prescribed. And he ended up with terrible drug interactions and needed 2 hip replacements. As a result, he still struggles to trust doctors, and he still struggles to take his medication, and it's completely understandable. Respond openly and honestly to questions about medication and side effects, and provide motivational support, but don't be disappointed with non-adherence. Try to understand it and respect our patient's decision. So I'm just going to quickly go through a couple of case studies. These are not the patient's real names, and there's no identifiers at all with any of the patients that I'm going to be talking about. So this was a patient, let's call him Ben. He was 22 years old, and I was quite heavily involved with him a couple of years ago in terms of looking after him as a nurse. He'd had HIV since he was born. And he was told he was HIV positive at the age of 15 years old. Couldn't have been a worse age to be told he was HIV positive, going through adolescence, teenage years. And he, quite understandably struggled with acceptance. And there was a really, really big power struggle. Remember, I talk about control and that need for control and that need for power earlier on in this presentation, but there was a power struggle between Ben and his mum. His mum was desperate for Ben to take his medication, and she used to show him films, of people dying of AIDS to try and frighten him into taking his medication. And of course, it just did the opposite. Ben stopped taking his antiretroviral therapy. And because he was so young, in MDT discussions with consultants and the nurses, we were beside ourselves, because we desperately wanted this young man to live. We wanted him to take his medication. He was constantly telling us he didn't want to live. He wanted to die. He wasn't frightened of dying. But none of us listened to him. And he died at the age of 22 years of age from end-stage HIV on the infectious diseases ward. And I have reflected on this patient over the years. I've reflected so much, because what we deprived him of was actually preparing him for a good death, and also preparing his mum and his sister for the fact that he was going to die. And if I could do it all over again with Ben, I'd have referred him to palliative care services, and I would have made sure that he died in a place where he wanted to die, and that his mum and his sister had really, really good preparation for his death. And then we've got Peter, who's 30 years old, and a couple of years ago, he decided he would rather die. He was very, very clear that he could not accept his diagnosis. Taking HIV tablets every day just made him think of his HIV, and he no longer wanted to think about HIV. So he stopped taking his antiretroviral therapy. We, as a team, really respected and accepted his decision, and I referred him to the palliative care team. We also had a do not resuscitate put in place because he didn't want resuscitating. He also didn't want active treatment. We did advanced care planning with him, and he very clearly said if he ended up in hospital with pneumonia, he did not want treating. He wanted to be palliative, and he wanted to die. And we visited this man for about 2 years, and really it was just to listen to him and maintain that engagement. In November 2018, he suddenly decided he didn't want to die, and he started taking his antiretroviral therapy. And presently, you know, he's undetectable, and his CD4 count is above 200, and he's happy, and he has come to accept his diagnosis. So that was a really, really good outcome, but we accepted him. We accepted where he was coming from. And then the last case study is Paula, 38-year-old lady who we looked after for quite a long time. We had intermittent engagement with her for 5 years. She really did hold us at arm's length. She was a hoarder. She was a strong religious lady. And she believed that God had healed her. And actually the pastor, the leader of her church, had told her that by taking her HIV medication, that was showing a lack of faith. So she'd stopped taking her HIV medication. She ended up being admitted to hospital with a CD4 count of 11, and she was discharged 3 days later, clinically dying, and we got her admitted into the hospice for end-of-life care. And during her first few days in the hospice, I don't know what happened, but she suddenly decided that she wasn't ready to die. And while she was in the hospice, she started taking her antiretroviral therapy. And it was amazing to see this woman just come back to life, really, and start putting on weight. And she's undetectable currently, and she also has a CD4 count of over 200. So again, a good outcome. So just to conclude, people are complex. We're all complex. Trust is the most important factor in patient satisfaction and adherence to care. Our patients have got to be able to trust us, and they have to be able to feel they can be open enough and tell us their fears and their concerns. And as healthcare professionals, we need to develop a concordant relationship with our patients. It's got to be an equal relationship. It's vital to understand the psychological reasons and issues which lead to someone choosing to opt out of ART, so that we're better able to help our patients on their journey. And I feel very strongly about this, but our duty of care remains the same with patients who choose to stop taking their treatment, as exactly the same as patients who continue to take their treatment. And our care should always remain high quality, no matter what. So thank you very much.
Thank you so much, Liz. That was a very powerful, emotional presentation. We can really see the years of experience you have in your clinical work and how wonderful you must be with your patients. Thank you so much.
Thank you, Jane. Thank you.
Yeah. For our final presentation, we have William Matovu. He's going to talk about U equals U, a motivational message for HIV treatment adherence. I'll tell you a little bit about William. He's a youth born and living with HIV who works with the Love to Love organization as an HIV educator. Love to Love is a nonprofit organization based in Uganda that is creating awareness about HIV/AIDS and supporting youth and children who are infected and affected by HIV. In 2010, at the age of 16, William started advocating for the rights of people living with HIV because of the stigma and the discrimination he had experienced after the death of his parents through HIV. And he's never stopped. He's passionate about social media. He uses it as a platform to communicate accurate and important information about HIV, and he's dedicated his life to doing this. In 2017, he started championing the U equals U message in his community to ensure that people living with HIV have access to treatment and to fight stigma and discrimination among people living with HIV and the general public. He has participated in several conferences to present U equals U. In 2018, he was presented in Uganda at the AIDS 2018 conference in Amsterdam as well. And in 2019, he was a keynote speaker for U equals U in Africa. So we're very lucky to have William here today to present a message to us about U equals U. We're going to make sure we get the technology right. We hope he's going to be able to share his screen, but if not, I have his slides and he can talk. So William, are you there? Are you able to show your slides, or would you like me to?
Okay, let me.
While he's setting that up, I meant to say, I do believe the comments box is open. So anybody listening at this time in this live presentation, you're able to write comments. I'll try to monitor them, and then we will have 5 or 10 minutes at least at the end of William's presentation to address them. So I'm sorry, William, did you say, are you there? Can you see us, or do you need me to show the slides?
Hello? Hello?
Hello, William, we can hear you barely.
Can you hear me now?
Yes, that's better.
So I've shared my screen. I'm going to start my presentation.
Let's wait and make sure we can see your screen. And you need to speak as loud as you can.
Hello?
Yes, that's better.
Can you see my screen?
No, we cannot.
But I've shared.
Okay, so I'm going to share my screen where I have your slides. So can you see the slides now, everyone?
Can everybody see my slides?
Well, Mia, if you want.
Hello?
So I can show.
Hello?
Let me see, William, why don't you talk? I don't know if you can,
Are you seeing my slides?
Yeah, I think you're seeing them now?
Yeah.
Okay.
Let me
so
see.
I'll stop. Jane, we can, okay, so William, if you look at the presentation, you're going to see my slides, okay? Because we can't see your slides. So you can just talk and you can tell me when you want to go forward, okay? So right now you see the title slide. Can you see that?
I'm not seeing anything.
Okay, can you open on your computer your presentation so that you can see your title slide? You just open your PowerPoint, even though we can't see it, because I want you to be able to follow along.
Okay.
Okay, you have yours open and you see the title page?
Yeah.
Okay,
Sorry.
so you just use that, and every time you want me to go to the next slide, you tell me and I'll move on.
Are you seeing my slide now?
No, we can't see your slides. We're going to use my slides. So
Okay.
you can look at your slides, and I have them all, and you just tell me when you want to go forward. So right now I'm seeing the title slide, and you can just present you can start.
Okay. Hello, everybody. My name's Matovu from Uganda, and I'm gonna present about U equals U, a motivational message for treatment adherence. Next slide. My presentation layout will be introduction. What is U equals U and what does it mean? Glancing back and moving forward in treatment research. The impact of U equals U message as far as adherence is concerned. Challenges encountered while spreading this life-changing message. Conclusion and contacts. Next slide. Okay, when Jane began introducing me, she talked all about what is concerning about me, my work and my activism. Next slide. Next slide. Okay. What is U equals U? Before I proceed further, I would love to the audience to know about what is U equals U and its meaning. You could be wondering what is U equals U. You could have a question in your mind. Uh, what is U equals U? U equals U in full is undetectable equals untransmittable. It means that somebody who is effectively taking his medication and maintains undetectable viral load of less than 200 copies per milliliter cannot pass on the virus to his or negative partner sexually. And the science tells us that the risk of sexual transmission is zero. And we have to say that zero risk equals zero excuses. The time of excuses is over because we have science. Different studies have confirmed that somebody who is on effective treatment and maintains a detectable overload will never pass on the virus sexually to his or negative partner. Next slide. Okay, so we have seen a number of research that has been done. We are going to glance back and move forward. So I have these two gentlemen here, Dr. Julio Montana and Bruce Richmond. Dr. Julio Montana is the founder of TASP, that is Treatment as Prevention. The concept of U equals U was drawn from TASP, Treatment as Prevention. So this man, Dr. Julio Montana, came with a landmark study known as HPTN 052. So, which showed that people living with HIV who achieve and maintain undetectable overload can not pass on the virus sexually to their negative partner. So, I love this gentleman, Bruce Richmond. When he knew about that he cannot transmit HIV to his negative partner, he asked the doctor who told him that you cannot transmit HIV. So he was so curious and asked his doctor, why is this message not spread in the entire world? Because people would love to know this kind of information. So with his fellow activists around the world, they came up with this concept of the U equals U. Next slide. So why is it a motivation message? U equals U, we want to see how it is impacting the society that we're living in. Basically, my first point is it dismantles the internal stigma and external stigma. Whenever me here in Uganda, I've tried sharing this U equals U message to different people. Whenever I share about this message, people shy away from stigma and fear because because of when the epidemic came in the early 80s, it came with a bad face. So people started fearing HIV, but because we have the science now, we can dismantle stigma and discrimination. So we no longer have to fear. Another point is it creates harmony among discordant couples. So if I share like me, for example, I am in discordant couple relationship. My girlfriend is negative, but when she showed, when I shared the information to her, she was so happy. So, and we are living in harmony with her because she knows the science behind U equals U. Another thing, the U equals U prevents plans from defaulting their treatment. This means that if health workers teach or educate people living with HIV in their facilities about this science of U equals U, it means uh, they will stop defaulting treatment because U equals U is a hopeful message. It gives hope and courage among people living with HIV and those who don't live with HIV. Next slide. Next slide. Okay, so there are challenges. Sorry, go back. Okay. Challenges encountered while spreading out, preaching the gospel of U equals U. First of all, HIV colonialism. Why? I mean that people with HIV colonialism are meaning that people with many people withhold vital information about HIV. For instance, when I began spreading the U equals U in 2017, we lost funding from a lady from US because we are spreading the U equals U message. And this we have to fight this because it is most seen in Africa because they think that we are inferior. So that's why they don't want us to get accurate and meaningful information about HIV. Another point is financial support. If we get financial support, we can preach this gospel widely around the world. Uh, we also face dogma and naysayers. Many people think that things have to be like they used to be in the early 80s when the epidemic came. So, yet we know that HIV science is dynamic, it's not static. Research has been done, things have changed, so we have to fight dogma and naysayers. Uh, Another problem that we face when you're preaching the gospel of you because you around the world, it is most people think that this campaign is only in the favor of the LGBTQ community, which is not right because HIV affects all people living with HIV, regardless of their sexual orientations. Next slide. So, as I'm concluding, I have a few recommendations. If we embrace the you equals you message, we can end HIV before even a cure comes. How? Let us use the message to advocate for treatment access for all, HIV testing and routine viral testing. This means that those who are on treatment will remain happily positive, and those who are negative will never get infected. So another point is we should use the U equals U as a chief sensitization tool. U equals U should be used as a chief sensitization tool. This will help a lot in curbing down infections, stigma, and discrimination, and criminalization as well. Next slide. So those who want to follow me or love organization and prevention access campaign as well, these are some of the links that you can click on and see how I do my work and our organization plus prevention access campaign. Next slide. Thank you so much. But I have a song that I want to play for you. Thank you so much. God bless you all. I'm very, very glad that I've been given an opportunity. Okay. You playing the song? This song is all about you because you. It is one of my songs that I write. I'm a musician. I write advocacy music. So thank you so much for giving me this opportunity. I'm very, very glad to be part of the panel. Thank you so much.
Courage really gives me hope for the next generation. Thank you so much. Okay, sorry, of course, I was muted, so you couldn't hear his beautiful music. I'm sorry. Hopefully he can share that in another forum. I got to hear it. It's a very nice music. Okay, we have a few minutes. We're supposed to end at 27 past the hour, so we have time for a couple questions. Looks like Reve Miko has a question for Liz. These are hard topics which need attention. Thoughts on how this may resonate with retention and care or lack of care when discordant. Not sure if you understand that better than.
Yeah.
Okay.
Do you want me to say anything?
Yes, please.
Yeah.
That was.
I mean, I think what happens, what I've seen over the sort of the 20 odd years of working in HIV, I think what happens is that when someone is really, really struggling to take their medication, they're missing appointments, they're detectable, we're not very good at keeping those patients engaged in care. And I think I've had so many patients over the years say, I didn't go to clinic because I knew I'd get told off because I was detectable and I wasn't taking my tablets properly. And I think we have to change the way we I mean, I don't want to sound like I'm blaming healthcare professionals. I'm talking about myself as well. But I think we almost have to change the focus of clinics, which seem to be so focused on adherence and whether you're undetectable or not. And actually, the focus of clinic appointment needs to be holistic and about that whole person and about the struggles they're having. Because actually, I think when patients feel listened to, they're much more likely to stay engaged and make hopefully start taking their medication again. I've probably not answered that very well.
No, that's okay. That's okay. It's that complicated topics, which are hard to cover briefly. But we did have another question. Jonathan Hess wrote, "Thank you so much, William. Can you share the views of the Ministry of Health and UU in Uganda as well? And which donors have supported UU outreach in Uganda?" So what's the Ministry of Health and Uganda saying about U equals U? Are they supportive?
Actually, the Ministry of Health in Uganda has not supported
Oops, I'm having trouble hearing you. I don't know if others can.
the message of U
Very
equals U.
loudly.
He has not adopted. Hello?
Hello, now we can hear you.
So I was trying to say that the Ministry of Health in Uganda, it has not yet adopted the U equals U message, but we're fighting so much to push them to endorse the message. We try to go to different people, even by the time we organized the first U equals U conference in Africa, here in Uganda, we reached to them, but they didn't come to our conference. So we made it ourselves with other partners. And another question, that which donors have supported U equals U outreach? Nobody has supported U equals U outreaches here in Uganda, apart from the Prevention Access Campaign, the founding organization of the U equals U.
Okay, William, we had another question from Nada Fadul, who asks if you face any skepticism or challenges from people living with HIV who are affected by internal stigma.
Yes, we have faced a number of challenges by internal stigma, but whenever we preach the gospel of U equals U to such people, they get relieved, and at times they come out publicly to say that they're living with HIV without fear. Hope I've answered the question.
Okay. Okay, thank you. I had one question for Ethel, and I know you're a clinician too. And so dealing with patients, people have heard rumors of long-acting antiretroviral therapy, and some of them are wondering, when will it actually impact me? When will it have an effect? Is there a message of hope and optimism that you can give to them at this point? Do you know how soon they might be able to think about these new options?
Yeah, it's interesting. Thanks for that question, Jane. So I'm a site investigator for the ACPG 5359 study, and I've had a lot of participants looking at long-acting cabometyl in non-adherence and in individuals experiencing non-adherence. And I've had exactly 180-degree opposite conversations with participants at the moment of randomization. One who said it would be such a crushing blow if he wasn't randomized to the injectable arm that he couldn't even go on. It would be so intensely disheartening for him. And one who said he would actually drop out of the study if he was randomized to the injectable arm. So I've seen the entire range. Both of those were highly emotional conversations, and I've seen the entire range of patient preference. But the people who are very excited about it, the one in particular who said that randomization to the oral arm would be a crushing blow, he said he's been asking for shots for 15 years. He's like, I thought of this a long time before all of you started making this possible. So I've been wanting this and I need to know that it's on the horizon. And so I basically said, it's not just on the horizon, it's next door in Canada, approved and widely available. It's going to be approved in Europe. It's probably going to be approved here in early 2021. So it's really close. And whatever stopgap measures for raising morale or just supporting you through the time to when it's available, we can do, because it is short.
Okay, that's great news. Well, I think we're going to draw to a close, give people a couple of minutes before the next, but I wanted again to thank our speakers, Drs. Ethel Weld, Liz Foote, and William Matovu, for an excellent presentation. It was international, it was interdisciplinary, and we got a sense of both the research and the clinical perspective. So thank you very much. Despite a couple audiovisual glitches, I think we were able to pull it off. Thank you for the IPAC staff for supporting us. And I hope you all enjoy the rest of the conference. We'll be back for a very brief break. Thank you all.
Thank you so much.